So this will be the first of two talks on measurement of perfusion with MRI. I'll be talking about methods which use gadolinium bolus, and then Ron Wolf will be talking about the non-invasive arterial spin labeling methods. Perfusion MRI using gadolinium goes back to around 1991. This is one of the early papers on this from the group at MGH. And this basically sort of proved the feasibility of the method. And they also did a visual stimulation experiment. And they saw how the blood flow changed. So the wash-in curve here comes a little bit earlier and has a little bit higher amplitude when there's visual stimulation than in darkness. So this was kind of a precursor also to functional MRI. Although, of course, these days functional MRI isn't done using gadolinium bolus. So this is one of the early papers demonstrating the feasibility of the technique. Now, gadolinium actually has two different effects on the MRI signal. Gadolinium, of course, is a paramagnetic compound, and when you put it into the bloodstream, it shortens the relaxation times, the T1 and the T2 relaxation times of the blood. If the blood-brain barrier is disrupted, it gets into the brain, of course, then it will shorten the relaxation times of the brain signal also. That's everything, everybody is familiar with that, of course. Now, the other thing it does, because it's paramagnetic, it also causes a change in the magnetic field strength. If you imagine this is a blood vessel, if you put gadolinium inside the vessel, it actually increases the magnetic field strength inside of the vessel. But interestingly, it also has an effect outside of the vessel. So in some areas, the field strength is increased. In other areas, it's decreased. And this causes a dephasing of the MRI signal. So if you're doing gradient echo imaging, the gadolinium will show up dark in the region surrounding the vasculature or the microvasculature. And this is the effect which is used for perfusion imaging. Basically, what happens is when you're doing these experiments, you start the scanner running, you're typically using a gradient echo EPI scan, and then you bolus in the gadolinium through the antecubital vein. And about 10 to 15 seconds after you do the injection, you will see basically, first of all, the arteries go dark, and then the brain goes dark, and then finally you'll see the signal in the venous circulation. If you draw a region of interest on your image, you'll get a curve something like this as the gadolinium washes in and washes out of the brain. Now the question is, okay, I've got a curve like this. How do I measure blood flow from this curve? And actually, people have been thinking about this for a long time. One of the early papers was from 1894 from Stewart. And some of you may be wondering, you didn't think they had MRI in 1894. And you would be right. Actually, they had a different detection device. It was called basically the human eye. And they injected a dye, into these rabbits, or whatever, and they could make a curve like this just using visual methods. But the math of solving this curve to get a blood flow is basically the same. So actually, this is something which has been known for a long time. So how do you do it? Well, the first thing you do is you recognize that we think that the gadolinium concentration is linearly proportional to the change in the relaxation time, the R2 star relaxation time. R2 star is 1 over T2 star. And so the first thing you have to do is, instead of plotting your signal versus time, you plot R2 star versus time, or particularly the change in R2 star. And you can get that simply from the logarithm of the signal divided by the baseline signal divided by the echo time. So now we have a curve which goes up, and this is sort of a surrogate for the gadolinium concentration in the pixel that you're looking at. So the first thing is we can calculate blood volume. Well, how do you do that? It's actually pretty easy. You just look at the pixel somewhere where there's 100% blood volume, either an artery or a vein, so this has to be a big vessel. And we know that corresponds to 100% blood volume. So if you take a pixel in the brain, then the blood volume of the brain is just simply equal to the ratio of the delta R2 star in the brain divided delta R2 star in the artery. This would be a percent blood volume. You can get blood volume in units of ml per gram if you divide by the density of tissue. Now, also remember, this is a dynamic experiment. The gadolinium is washing in and washing out from the brain. So actually, you have to integrate the whole time course of that wash-in and wash-out curve, at least the first pass, in order to get these measurements. So these are actually integrals over the first pass of the gadolinium coming through the brain. So that's blood volume, but blood volume is kind of useful, and I'll show some examples later of how blood volume can be clinically useful. But often you're really interested in blood flow. For instance, you can have it's just simple plumbing. Basically, you have a large pipe, but if there's no flow going through the pipe, if the blood is just sitting there, then your blood flow is very low. Or you can have a small pipe, you can have a small vessel, but if there's a very fast rate of blood through that small vessel, then you have a high blood flow. So to get blood flow, you have to do a little bit more work. And the key concept here is something called this central volume principle, which was actually first published in 1954 by Meyer and Zieler, who were here at Johns Hopkins. And basically the idea is here that there's this concept of the tissue residue function. So let's say you could instantaneously inject a little gadolinium somewhere in the brain, and then you waited a few seconds and you measured how much was left. Well, that's what the tissue residue function is. So at the beginning it's 1, and then eventually after an infinite amount of time it would be 0. If you take the average value of this residue function, that is what is known as the mean transit time. And the central volume principle states that cerebral blood flow is equal to cerebral blood volume, which we just saw on the previous slide how to calculate, divided by the mean transit time. And that's how you can calculate cerebral blood flow. So how do you do this in practice? Well, it's a little bit scary because you have a big equation like this. So here, you can think of this as the delta R2 star of a pixel in the brain at every time point of our dynamic series. And that's equal to the blood flow times this matrix here, which is the arterial input function at each time point. So this is a pixel, delta R2 star, and a pixel located in a major vessel, and then times the residue function. Fortunately, this is solvable, and one of the standard ways of doing this is using something called singular value decomposition. And this is really described in the landmark papers by Ostergaard from about 10 years ago now. Now, this is kind of a difficult calculation to do. Fortunately, now there's a program available to do that for you. It's called a Penguin program. It's actually a free download. And it can produce maps like this, so maps of mean transit times. Here's a patient with a left MCA stroke, and you can see the mean transit time increase, particularly in the frontal deep white matter. Actually, some vasodilation, some compensatory vasodilation in the cortical regions on the blood volume map, and also perhaps a little more subtle to see, but decreased blood flow, particularly in the left frontal lobe. This is a little bit tricky to use in a clinical situation, this program, but I think it's a very valuable research tool. I do want to point out that even though this produced maps of blood flow, you should be aware of there are a lot of problems, limitations with this technique. And they're kind of listed here what the major problems are. Well, one question is which artery should you choose? And this is something I struggle with all the time. You have a stroke with an occluded middle cerebral artery. There's no signal there, so what do you use? Most people use the contralateral MCA, but it's arguable as to whether that's really correct or not. There's a major problem with partial volume with this technique, because if you think about a large vessel, maybe sort of 1 or 2 millimeters in diameter, that is smaller than our MRI pixel size. Typically, we do these with slices of 5 millimeters thickness. So you always have partial volume. You can never really get a pure arterial input function. Is also, I alluded earlier that we believe that the delta R2 star is linearly proportional to the gadolinium concentration, but that is probably not true, and there may well be differences in this proportionality constant here between the large vessels and the microvasculature. So that's another source of error. And then finally, when you have a stroke, you're measuring your arterial input function sort of downstream, and it can take several seconds for the gadolinium to actually arrive in the region of interest in the brain. And that delay will also cause problems to the algorithm to calculate blood flow. So all of these put together basically means you can't calculate absolute blood flow with this technique. However, that's not to say that the measurements of relative cerebral blood flow could still be very useful. So in practice, you're probably not going to be calculating blood flow if you're doing this in the clinic. So how are you going to analyze the images? And actually, there's some very simple hemodynamic parameters that can be clinically useful. So here are three curves here. This is a scenario where you have high blood flow. All three of these curves have the same area, so they all have the same blood volume. So this is high flow, and you can see that the time to peak is shorter than normal flow, and when you have a low flow situation, the time to peak is increased. So time to peak is a parameter which is inversely proportional to related to blood flow. And similarly, the peak height is also changing. So when you have high flow, the peak height response is higher. So in practice, most people measure this time to peak as sort of a surrogate marker of related to flow. And here's just one example. So here's a patient with a large right MCA stroke, and you can see on these time to peak images, you can very clearly depict the regions of hypoperfusion. If you look at a histogram of the pixel intensities, you can see in this example, this is the normal brain here. So the bolus is coming in about 30 seconds after the start of the scan. And then there's another group of pixels out here where the bolus is coming in around 40 seconds. So there's about a 10-second delay difference between the normal brain and the region of the stroke. And this is very typical for ischemic brain. Typically, we say that if the delay is more than 4 to 5 seconds, then we believe that the brain is ischemic in those regions. It seems like mean transit time and time to peak are very tightly correlated. There was some discussion that whether mean transit time was a better indicator of low flow than time to peak. In some of the studies we've done, we found that they're very tightly correlated, so they're probably largely equivalent. And this is the typical pattern you see on perfusion imaging when you have a either high-grade stenosis or total occlusion of the internal carotid artery, and you see this sort of hemispheric pattern of hypoperfusion. Very dramatic on the perfusion images, but actually often these patients are totally asymptomatic and don't have any lesions. So in this case, this patient was having a stroke, and you can see some hyperintensity in the deep white matter on the diffusion weighted image. So one of the things that perfusion imaging could be quite useful for is monitoring the success of reperfusion therapies. So this was a patient this is a very interesting patient who was actually globally aphasic, and this scan was done 4 days after the onset of their symptoms. And you can just see the scattered infarcts on the FLAIR scan in the deep white matter. But the reason this patient is globally aphasic is the hypoperfusion, the cortical hypoperfusion here of Wernicke's area. And this patient went to an emergent endarterectomy and was clinically normal after the endarterectomy, quite remarkably, because they were treated 4 days after their stroke onset. And you can see why they are now normal again, is that the perfusion has been restored to the cortical regions. So this is pre-endarterectomy. You can see this sort of hemispheric hypoperfusion, worst in the deep white matter, and then post-endarterectomy, basically completely normal and symmetric. So other patterns which are quite characteristic on perfusion imaging, well, one example I like to show, this is moyamoya disease. And basically this is bilateral moyamoya. So if you want to do a sort of comparison, where is the normal part of the brain to compare to? In patients with the moyamoya, it's got to be the posterior circulation. So you can actually see this yellow color here is normal flow in the cerebellum, and then this patient has low flow in both of the hemispheres. And of course, there's also high flow, or at least a normal flow, in the basal ganglia, where they have this all these moya vessels. This patient also underwent a procedure to attempt revascularization, and this was an encephalomyosynangiosis, where they basically suture a muscle flap onto the surface of the brain and to try and establish flow that way. And you can see actually in this patient it was pretty successful. Here it was done in the left hemisphere, and you can see this is 1 year later after the procedure was done. There is actually pretty good perfusion now of much of the left hemisphere following this procedure. I have actually 3 or 4 other cases. I've not shown them here, none of which where this procedure was successful, but this is an example of one procedure where it was successful. Something else which I think is clinically quite important is the question of ruling out stroke in patients. Now, as I think I'm sure everybody knows, I mean, diffusion-weighted imaging is probably regarded as the sort of primary modality for identifying acute ischemic changes in the brain. And but I just want to point out that occasionally, and this is pretty rare, maybe very rare, but occasionally it can happen that the diffusion images are negative even while you have a perfusion deficit. And this is just one example we had. This was a patient who actually came in with fairly mild symptoms. His NIH stroke scale was only 3, that's pretty low. And he was scanned 3.5 hours after symptom onset, just outside the window for IV TPA. And we thought this patient would do fine because his conventional MRI was normal, his diffusion-weighted scan was normal. And this was in the very early days of us doing perfusion imaging, so we weren't able to look at the perfusion data right away. But a few hours later, when we were able to process the perfusion images, we said, uh-oh, he's got a big perfusion deficit here. And actually, he clinically worsened, and 4 days later came back and now has this nasty hemorrhagic stroke in that region, which was previously hypoperfused. So the message here is that if there's a strong clinical suspicion of stroke, it's really advisable to do both perfusion imaging as well as diffusion imaging. Perfusion imaging also has been shown to give you a better sort of clinical correlation than diffusion imaging. So here's an example. These are 3 different patients with strokes in the non-dominant hemisphere, in the right hemisphere. And the clinical test they were asked to do, this is a test called the Ogden scene. And the patient is basically given a picture. There's like a tree and a couple of trees, a house and a fence. And they're asked to make a copy of it. And so this is sort of a test of neglect. And you can see, for instance, this patient down here, fairly small stroke on diffusion image, normal perfusion, and they're able to make a perfect copy of this figure. This patient, similar size infarct to the previous one, some perfusion deficit, can partially reproduce the picture. And then this patient here, again with a small infarct on diffusion imaging, but with this large area of hypoperfusion, is basically completely unable to replicate the picture. So this is kind of a busy slide, but the summary of this is that perfusion imaging correlated much better with these clinical measures than did diffusion imaging. It was also interesting, if you split the strokes up into dominant versus non-dominant hemisphere strokes, that actually the conventional way of evaluating a stroke patient, the NIH stroke scale, when you looked at the non-dominant hemisphere strokes, did not correlate at all with the perfusion findings, because the NIH stroke scale is kind of weighted towards the dominant hemisphere. It has a big motor component. But when we looked at specific tests for the non-dominant hemisphere, neglect testing, we did find a good correlation with the volume of perfusion abnormality. In the dominant hemisphere, left hemisphere, we found the best correlation between perfusion imaging and motor type measures. Just one other example before I leave cerebrovascular disease. You can also use perfusion imaging to look at venous abnormalities as opposed to arterial abnormalities. This is a patient with Sturge-Weber syndrome, and you can see the extensive atrophy of the left hemisphere and leptomeningeal enhancement. The venous angioma these patients have causes basically venous congestion, slow flow. And you can see that when you look at these wash-in and wash-out curves here. So the yellow one here is in the normal hemisphere. When you look at the abnormal hemisphere, you can see in this region here, the arterial arrival looks fairly normal, but then there's a very slow washout. If you go to the most severely affected area here, actually the arterial arrival is somewhat delayed. But again, there's a very, very protracted venous washout. So this could also be useful in looking at abnormalities of the venous system. Now, just in the last 5 minutes or so that I have available to me, I want to talk about the other main clinical application for ganglion perfusion imaging, and that is looking at mass lesions in the brain. And there are a couple of references here. It's a review article, which I think is very good, and this is an article on tumor-factive demyelinating lesions, which I thought was interesting. Basically, when you're looking at mass lesions, you're not so interested in the dynamics. You're not looking at blood flow or time to peak, but you're looking at blood volume. And this is kind of a measure of the angiogenesis of the lesion. And so these are just two examples. One patient with a tumor-factive demyelinating lesion, one patient with a GBM on pathology. And when you look at which have a sort of similar conventional MRI appearance, when you look at the blood volume image in the tumor-factive demyelinating lesion, the blood volume is actually low. I contrast that to the high-grade brain tumor where the blood volume is increased. So this is from this paper. They found in the demyelinating lesions that the CBV, this is expressed relative to the white matter in the contralateral hemisphere, ranged from about 0.2 to 1.8, whereas the intracranial neoplasms, these are mainly high-grade neoplasms, it was about 1.6 to 19, so there was pretty good separation of these two groups. So basically, this could be useful looking at blood volume from distinguishing non-neoplastic lesions from neoplasia. Just a couple of examples from our own work. This is a patient we saw fairly recently, and the question here was: this patient was this a stroke or a tumor? Bright on diffusion-weighted image, but mainly shine through, actually elevated ADC. And could be a sort of vascular distribution type lesion, but no little bit of enhancement. When we looked at the blood volume images, sometimes it's a little bit hard to read. You have to window these just right because blood volume images are typically dominated by the major vessels in the brain. So you really need to sort of window these so you can see contrast between the sort of white matter and gray matter. And here we can see out in the cortex here there's definitely increased blood volume. So this would be consistent with a tumor, and we also did spectroscopy in this case, and there was a high choline signal also consistent with a tumor. And also in the spectroscopy there was no lactate, which if it was a stroke we might expect to see some lactate. Another example, this was actually a patient who was with a right frontal lesion here, which was read as an astrocytoma on an outside scan, and was coming in for a biopsy, and these are the pre-biopsy scans. And at first sight, we actually also thought this may be a astrocytoma because it has a high choline signal. Here you can see here. But that's not 100% sure because we know that demyelinating lesions can also have high choline. But two things tipped us off that this was not an astrocytoma. And the first was the very low blood volume here, but also the incomplete ring enhancement, this U-shaped enhancement, very characteristic of a tumor-factor demyelinating lesion. And, I don't have the follow-up, but 3 weeks later, this lesion had almost completely disappeared without any intervention. So just finally, I just want to talk very briefly about the practicalities of doing perfusion imaging with gadolinium. And you can use a single dose of gadolinium, that's fine. Traditionally, we've used a double dose, but as we now get a little bit more concerned about the potential harmful effects of gadolinium, particularly NSF, it's actually no problem to do this with a regular single dose of gadolinium. Preferably, you want to power inject it at a rate of 5 cc's a second, and then it's very important to follow it by a saline flush at the same rate and equal or greater volume. And if you've got small children or people with poor veins, it's okay to use a hand injection as opposed to a power injection. Typically, you want to use an 18 gauge or larger catheter to get a good bolus. Now, in terms of the imaging characteristics, you basically want to use a fast imaging sequence like echoplanar imaging. I think pretty much these days everybody uses echoplanar imaging because you want good time resolution. You want to look at these wash-in and wash-out curves. So absolutely the slowest resolution for this, I'd say, is 2-second TR, and it's actually better if you can do like a 1.5 or even a 1-second TR to really finally digitize that wash-in and wash-out curve. Most people use gradient echo EPI because you get the most contrast. You can use spin echo EPI, and you're basically have less contrast. You have this less problem with the major vessels with spin echo EPI. But the trouble is the signal is also a lot smaller from the microvasculature. So for that reason, most people use gradient echo EPI. And this susceptibility effect gets bigger as you go to higher fields. So this method actually works better at 3T than at 1.5. Or if you go to higher field, you can use a little bit shorter echo time, squeeze in more slices, and get similar contrast. So when you're designing your protocol, there's basically a trade-off between how much coverage of the brain you want, and I think it's very important to do whole brain coverage, what spatial resolution you want, and what temporal resolution you want. So this is what we're currently using on our Philips 3T system. So using a single shot gradient echo EPI and time resolution of 1.5 seconds, echo time of 40 milliseconds with sense encoding to speed it up. And we're doing at least 20 slices to cover the whole of the brain with a 4 millimeter slice thickness. And this scan lasts 1 minute. And it's nice that the scanner actually reconstructs time to peak and blood volume maps for you right away as soon as the scan is finished. It's just one example. Here's some blood volume maps. This patient I showed you earlier. But you really see where the stroke is, where the hypoperfusion is on these color-coded time to peak maps. So this is my summary of my talk today. So I talked about the basic principles of perfusion imaging and how you go about quantifying the cerebral blood flow from this technique. In fact, time to peak, though, is a very good parameter if you just want a sensitive indicator of low flow. And we've looked at clinical applications in cerebrovascular disease, therapy monitoring, and mass lesions. We talked a little bit about the protocols to use for perfusion imaging.